So what is abdomen? It is a part of the trunk. It is a part of the trunk below the diaphragm. Okay, the diaphragm. There are many diaphragms in your body. It is a part of the trunk below the diaphragm. So the diaphragm, the main diaphragm in your body, separates the thoracic cavity from the abdominal cavity. There is another diaphragm in the pelvis also. That is pelvic diaphragm. Another diaphragm below that. That is urogenital diaphragm. Okay. Here there is another diaphragm. Oral diaphragm. Pollice diaphragm. So there are many diaphragms like this in your body. So the main diaphragm, that is the diaphragm, which separates the thoracic cavity from the abdominal cavity. So the whole of the abdomen, it is divided again into 9 quadrants by 2 vertical lines and 2 horizontal lines. Do you remember the 2 vertical lines? The 2 vertical lines. This is very important. The 2 vertical lines. So the 2 vertical lines are the mid-clavicular line and mid-inguinal point. So here it is mid-clavicular line joining the mid-inguinal point on right and left. And 2 horizontal lines. One is transpyloric plane and transtubercular. This is transpyloric, it is the vertebral level. It is lower border of L1. This is upper border of L5. So this transpyloric plane, it coincides with the pyloric part of the stomach, the fundus of the gallbladder, the hilum of the 2 kidneys, and the origin of the superior mesenteric artery, which is the artery of the midgut. Okay, all these structures, they coincide here in the transpyloric plane. And this is transtubercular plane. That is, we join the highest point of the 2 iliac crest. Okay, if you join the highest point of the, this is the iliac crest. If you join the highest point of the 2 iliac crests, you will find that line. So now, remember the 9 quadrants? This is the umbilicus. This is epigastric, hypogastric. This is right hypochondrium. This is right lumbar, right iliac. Similarly on this side, left hypochondrium, left lumbar, left iliac. And you remember the disposition of viscera. Everywhere you remember the disposition? So whole of the right hypochondrium, whole of the epigastrium, towards the left hypochondrium comes the liver. And here in the middle, the stomach. Here in the left hypochondrium, spleen. Okay? Then in the right iliac, cecum, appendix. Okay? And here you find the descending colon. Okay? Descending colon, sigmoid colon. Then the bladder, urinary bladder is here. Urinary bladder is here. Okay, so this is the disposition of viscera in the 9 quadrants of the abdomen. So, then I told you about the 8 layers. When you open up the abdomen, the 8 layers which you find from the superficial to deep. As you go on cutting, you find the 8 layers. You see the 8 layers? This is why I got the thing. These are the 8 layers. First, can you see the skin? Then comes this yellow thing, is the superficial fossa. Okay. Superficial fossa, I told you, just when you join the 2 anterior superior iliac spines, above that the superficial fossa is single layer. It is only fossa camper. Below that it is double layer. Superficial fossa camper and fossa scarpa. So whole of the abdomen, it is devoid of deep fascia. Okay, why? Because for pregnancy, that is for the development of the fetus, the abdomen has to protrude, the size increases. So, if deep fascia would have been there, it would not allow that. And you are taking the food, the stomach has to dilate. Okay, bladder has to dilate. For storage, it stores urine. Bladder has to dilate. So, for this purpose, the abdomen is devoid of deep fascia. What are the other layers which is devoid of deep fascia in your body? Face, then penis, all erectile, the function which have erectile function, they are devoid of deep fascia. Okay, then we come to the 8 layers. When you cut the abdomen, you just cut the 8 layers. That is the first the skin, then superficial fascia. Above this line, you cut single layer, that is lateral fat, that is called fascia camper. Then comes your 3 broad muscles, that is external oblique aponeurosis with its fascia, external oblique aponeurosis muscle with its aponeurosis muscle, the fleshy part, and the pubic tubercle. And you see, what is inguinal canal then? So it must be above or below. So just along this, it is an oblique musculoapparatic passage which length is 4 centimeter. So along this, I told you it is a grooved area. So it forms a canal like thing. Okay. So only 4 centimeter. It is 4 centimeter. But the length of inguinal canal is more. But the length of inguinal ligament is more. Canal is short. Okay. So if there is a canal, it will be, there will be an opening here and here. So in the there will be a superficial inguinal ring and a deep inguinal ring. Okay. So when you join from ring to ring, that will be the inguinal canal. So inguinal ligament is longer. Okay. But the inguinal canal is only 4 centimeter. Okay. So it is, the direction is downward, forward and medially, like that of the direction of the inguinal ligament. And it lies parallel above and parallel to the inguinal ligament. Okay. And there are 2 openings. I tell you, the deep inguinal ring. Deep means it will be a defect in the fossa transversalis. Fossa transversalis lies deeper. So deep inguinal ring is a defect in the oval shaped defect in the fossa transversalis. And the superficial inguinal ring is a triangular defect in the external oblique aponeurosis. Superficial, external oblique aponeurosis lies superficial. So if there is a triangular defect here, okay, that is the superficial inguinal ring. And deep inguinal ring is an oval defect in the fossa transversalis. And where does it lie? It lies 1.25 centimeter above the mid-inguinal point. Okay. So it is the extension for inguinal canal is 4 centimeter long. Then you see, what are the boundaries? The boundaries of inguinal canal. What are the boundaries? You see, just give a look at the boundary. The anterior wall, that is it is, you see, anteriorly, imagine, you will have to imagine it. Anteriorly what lies? The skin, the superficial fossa, external oblique aponeurosis. In the lateral 1/3 it is fleshy fibers of the internal oblique aponeurosis. This inguinal ligament to the inguinal ligament to the lateral 2/3 of the inguinal ligament, the internal oblique muscle comes and gets inserted. Okay. And to the lateral 1/3, the transversus abdominis. Okay. They take their origin and get inserted in the upper part. They will take their origin here, from below get inserted in the upper part. But external oblique took its origin from the lower 8 ribs, got inserted here in the iliac crest. Okay, clear? So these structures, the internal oblique and transversus abdominis, they will take their origin from below, go and get inserted upward. Okay, because the direction fibers are upward. And transversus abdominis, it takes its origin from here and gets inserted into the linea alba. Okay, so origin insertion, you see that, and you see what are the boundaries anteriorly. Anteriorly what will be there? Skin, superficial fossa and external oblique aponeurosis. Okay, how will you approach that? Then comes the roof. See the roof? So basic thing, the arch fiber. The roof is formed by the arch fibers of the internal oblique aponeurosis and transversus abdominis. I told you they take their origin from here. So they take their origin. So it will be the roof will be the arch fibers of the internal oblique and transversus abdominis. Okay. And the posterior wall, you see the parietal peritoneum and fossa transversalis. Okay, and towards the medial part, it is formed by the conjoint tendon and the reflected part of the inguinal ligament. You see. Okay. The posterior wall. Posterior wall, that is the parietal fossa transversalis. Below the fossa transversalis, what I told you? Below fossa transversalis, there is extraperitoneal connective tissue. Below that, there is parietal peritoneum. So, anteriorly, skin, superficial fossa, external oblique aponeurosis. Roof is formed by the arch fibers of the internal oblique and transversus abdominis. Posteriorly, fossa transversalis, extraperitoneal connective tissue and parietal peritoneum. All are linked to those 8 layers of abdomen. Okay, you will have to visualize that. Okay. So this canal, inguinal canal, it is only 4 centimeter just above the inguinal ligament. And inguinal ligament is nothing but the upturned portion of the external oblique aponeurosis muscle. Okay, clear? Then the floor. Floor is entirely formed by the grooved upper surface of the external oblique aponeurosis. Clear? And there are 3 extensions of this inguinal ligament medially. When you come medially, why it is important these 3 extensions? The 3 extensions of the inguinal ligament medially. When you come this is the medial part. So when you come medially, there are 3 extensions of the inguinal ligament. What are the 3 extensions? They are the lacunar ligament, the reflected head of the inguinal reflected part of the inguinal ligament and ligament of Cooper. Ligament of Cooper or pectineal ligament. These 3 are the extensions of the inguinal ligament medially. Okay. The lacunar ligament, it is a triangular shaped ligament here. I show you another diagram. It is like this. The apex is attached to the pubic tubercle and the base is concave. Okay. So that here there is inguinal canal, here there is femoral canal. Below this. Below the inguinal ligament, imagine, here there is a thigh. The lower extremity comes out. Okay, thigh. So, I told you that is the fossa scarpa. Fossa scarpa. It is attached to the inguinal ligament and below that to the fossa lata here. What is the deep fossa of thigh? That is called fossa lata. So, the line of attachment of the fossa scarpa, that is the abdominal fossa with the line of attachment of the fossa lata, is called Holden's line. Okay. So that when there is extravasation of urine, I come to that. Okay. So these are the 3 modifications of the inguinal ligament. That is the lacunar ligament, the reflected head of the inguinal ligament, reflected part, and the ligament of Cooper or the pectineal ligament. Okay. So why these are important? Because when there is inguinal hernia or any femoral hernia, we correct that during surgery. We correct this by putting suture on this. We strengthen these 3 extensions. Okay. So it is helpful for surgical purpose. So because inguinal canal, why it is important? Because inguinal hernia, it occurs through this inguinal canal. It is a defect in your abdominal wall through which the loops of intestine or omentum, anything may come out. So that is the inguinal hernia. Okay. So that is why it is important. So next thing you see, what are the content? I told you the superficial inguinal ring and deep inguinal ring. You see the contents. You see how This is the inguinal ligament, green color. This is the inguinal ligament, this is the pubic tubercle. Only this much is your inguinal canal. Okay, this is the deep inguinal ring, the triangular, this is the superficial inguinal ring. Okay. And this is the pubic symphysis. Okay. You see, these are the contents. That is the spermatic cord in male and round ligament of uterus in females. And ilioinguinal nerve, then fibrous remnant of the processus vaginalis in females, and artery to the round ligament of in females. So mainly you remember the spermatic cord in males and round ligament in females and ilioinguinal nerve. So now you see what are the constituents of the spermatic cord. These are the constituents of the spermatic cord. The spermatic cord, it passes through that, the inguinal canal. So what does it contain? So it contains that is the vas, that is the ductus deferens. In the middle you see, this is the vas deferens. Okay. Then the remains of the processus vaginalis, then testicular artery, cremasteric artery and artery to the ductus deferens, and these veins are the pampiniform plexus of veins which are around the testicular arteries. Okay, then the lymphatic vessels from the testes and nerves, that is the genital branch of genitofemoral nerve. Okay, all these are the contents of the spermatic cord. Then why the testis? The testis which is within the scrotum. Why we call that the scrotum is mini abdomen? Why we call it? Because whatever the layers I told you, those layers are found covering the scrotum. Okay, they form the covering. So within the scrotum lies the testis. So you see what I am showing you, it justifies or not. You see, this is the spermatic cord. What are the contents of the spermatic cord? I told you that it contains the ductus deferens, the pampiniform plexus of veins and all this. So this is the testis. So you see the coverings of testis from inside out. You see, or we will go from outside inwards. Okay. So it is covered by skin. The scrotum is covered by skin. Then below the skin, instead of superficial fossa, it has a dartus muscle. Dartus muscle. Okay. Which is a remnant of paniculus carnosus, that is the platysma. In 4 quadrupeds, you see when a cow passes, if a fly sits on the any part of the body of the cow, the whole of the skin of the cow, it waves out so that the fly goes off. But in human beings, it has due to evolution, everything has gone, only the paniculus carnosus part, that is the platysma muscle, the palmaris brevis, and in males the dartus muscle of the scrotum. This much remains in us. Okay. So below the skin, dartus muscle, then comes your, instead of superficial fossa, dartus muscle is there. Then comes your 3 broad muscles. So you see the remnant of 3 broad muscles. The aponeurosis of external oblique aponeurosis. So from the superficial inguinal ring, a pouch-like thing develops. That is called external spermatic fossa. Okay. From the superficial inguinal ring. Because you see the testis descends. Descends. So the testis will descend. So from the 5th week of intrauterine life, it enters into the deep inguinal ring. Takes a layer from here, that is the internal spermatic fossa. Okay, which is a remnant from the fossa transversalis. Okay, fossa transversalis is the deepest layer. So when the testis descends, it passes through the deep inguinal ring. Okay, and it enters into the inguinal canal, passes through the superficial inguinal ring. Then it enters into the scrotum by the end of the 9th month. So when a male child is born, just before we check whether the testis is descended or not. Okay. So it descends through this pathway. It enters through the deep inguinal ring, takes a covering with it. That is the internal spermatic fossa, which is derived from the fossa transversalis. Then again it is covered with the internal oblique muscle, that is the cremasteric muscle, which is the remnant derived from the internal oblique muscle, that is the cremasteric muscle. Okay, cremasteric fossa. Because when you tap on there is a cremasteric reflex. When you tap on the upper and inner part of the thigh, the scrotum it tends to move upwards. That we call it as cremasteric reflex. So that is due to the contraction of the cremasteric fossa, which is derived from internal oblique muscle. And the external the external spermatic fossa is derived from the external oblique aponeurosis. Okay, so it is taking its derivative from all the layers of the abdomen. So we tell that the scrotum is a mini abdomen. Okay, this justifies that scrotum is a mini abdomen. So now if you are asked that the external spermatic fossa is a derivative of external oblique aponeurosis, cremasteric muscle is a derivative of internal oblique aponeurosis, and internal spermatic fossa is a derivative of transversus fossa transversus. Clear? And within this we have the testis. Okay. So what is the application of the inguinal canal? So it is being a passage, that the entire thickness of the abdominal wall comes in, and it is a weakness through which the hernia occurs. So what is the hernia occurs? We name that hernia as inguinal hernia. Okay. So you see some pictures of the inguinal hernia, you will be convinced.